left off at the vascular diseases. The last few, literally just the last actual topic in cardiovascular. And then my plan is to add everyone into the, I'm going to send an email about this too, but add everyone into the dermatology videos that I had already done. And, you know, originally I didn't get too far with the videos I was doing, right? So I think let me check. I remember where I finished it off at. Because I feel like adding people into videos that I've already done, which is something I do for the Step 1 class as well, is much more efficient for covering topics that don't require a lot of teaching by me. If it's already done in the video, it's a lot easier for you guys and quicker. So last time I had finished actually all the way through epidemiology and ethics as well, which is definitely another topic that requires more practice on you guys' behalf rather than me teaching, and some of it is already stuff that's, you know, nothing is new in epidemiology and ethics in terms of content. I'm looking at it. So I had dermatology and endocrinology videos, epidemiology and ethics. After ethics, I wasn't able to do more because that was when the copyright issue came up. So I'm thinking that I'll add everyone that's still part of this in February to the dermatology videos, because there's absolutely nothing for me to talk about that in terms of teaching. Like cardiovascular was very intense and there was a lot of discussion to have, and I had to teach you guys how to look at ECGs and stuff, right? So that was good. For dermatology, I'm going to add everyone, and then I'm going to add everyone for epidemiology and ethics as well, because those are in the videos themselves. I've gone through a lot of very nice real-world practice questions, more discussion about how to understand things, and also some Step 1 topic revision. So that being said, those are topics that I'll go ahead and give everyone in February, and then we'll start off with endocrine pretty soon, actually, because we're going to be done with this with cardiovascular today, actually. So we'll wrap that up, and then yeah, endocrine. So February will give us time to, you know, just let you guys watch epidemiology, ethics, and derm on your own, while we delve into some of the more bulky things like the GIT and the hematology and oncology chapters that come after, right? Because if we look at the book right here, so GIT has obviously just as many things as Step 1 did, but you know, if we look at the contents, again, every single topic here is the same stuff you've already learned about in Step 1. So what you'd be seeing here now is how to know what test to order. Like if your patient presents with something that looks like it might be achalasia, how do you know if you order a test for the achalasia only, or do you need to rule out something else? How to identify that. This also gets a little more complicated when it comes to biliary disease and liver disease, right? So these things are more oriented towards, again, ordering tests, right? What kind of test should you order? So that gets pretty intense because you read questions and you feel like you know, and most times you do know exactly what the diagnosis is. You know what's wrong with the patient, and then you end up not knowing what test to order. Or you pick a test that would make sense to order, but not exactly for this pathology, it was for the other pathology, and stuff like that. So that's what I decided on doing for the February session. And throughout February, we should be able to wrap up GIT, because a lot of this is actually, so what often happens is, like, for example, all of these, for the most part, in the disorders of small bowel, you order the same test. So in that sense, you know, grouping things up and knowing where you're supposed to order the same test for all of these diseases is like an excellent way to revise and memorize CK materials, right? That's what I also did at the end of cardiovascular right here. So I'm going to do the same kind of checklist kind of thing for the other chapters as well. They're not in the book yet, but when I do add it, I'm going to send out an updated book, and I'll also put this same checklist in the email as well, so you guys can have it there as I do it. So for today, let's wrap up vascular diseases. So we have aortic aneurysm, right? Aortic stenosis, regurgitation. These are all the valvular diseases. We've already talked about the valvular things, but we'll look at what's over here. For vascular diseases, we have aortic aneurysm, which is usually going to be a question about the AAA, abdominal aortic aneurysm, although you could also have thoracic ones. Aortic dissection, which you have to remember, has nothing to do with smoking as far as the step is concerned, right? Aortic dissection is all about a dissection, a tear due to hypertension. And then DVTs, deep venous thrombosis, understanding how to look at the Wells score. So we're going to talk about these things right now and wrap it up with peripheral artery disease, you know, and then we're done. So let's get started. So first things first, what do they say here? So aortic aneurysm, greater than 50% dilation of all three layers of the aortic wall because you're dilating from inside to out. Aortic aneurysms are most commonly associated with atherosclerosis. So that's the answer choice you're going to pick, right? If you get a question about what was the most likely cause of this patient's presentation and your patient is presenting with an aortic aneurysm, you pick atherosclerosis. And if they don't have atherosclerosis as an answer choice, then remember the atherosclerosis, which is the topic we're getting up to in the Step 1 class. Atherosclerosis is one of those things that is just heavily related to inflammation. It starts off with the bad diet and having too much of a lipid content, high LDL, stuff like that. But atherosclerosis overall is an inflammatory issue. So the only other answer choice you could pick, if atherosclerosis is not listed as one of your answer choices for why somebody got an aortic aneurysm, the other answer choice is smoking. Smoking is the second thing that would make sense. Most are abdominal, and then and more than 90% of them originate below the renal arteries. So this is a really big topic. Let me open up first aid step 1 also, so I can show you guys what the discussion over there was. Right here. So if we look at, let me see, I think I have a picture of it too, so it'll help. Aortic aneurysm. So you see, like, they discuss arteriosclerosis and then jump into atherosclerosis in step 1, and then right after atherosclerosis is discussed and you look at all the main key things. Now I like having the book here for you guys too, so that when the video's on the playlist, you can pause and read it, right? So you can check this out too and get a good refresher of all the key technical silly little things. You know, you can see I bolded it or put it in red, things that are related to the pathophysiology of atherosclerosis. Right after that, they delve into talking about aortic aneurysm, which again can be abdominal or thoracic. And the reason they can be below the renal arteries, so let me see, like this picture right here kind of does justice to it. Yeah, you can see it. Okay, so you can see how in this picture, let me move it up. Okay, so the key thing here is you see below the renal arteries, what often happens is that you have this thing called the vasa vasorum, which is related to, you don't see it in this picture, but basically out here, let me actually do this in blue so it makes more sense, and you can see it on the red artery. So out here what you have are these venous vessels that go back upwards, right? And the beauty of that is that as these venous vessels are going up and the aortic blood is coming down, there can be an exchange of nutrients. This allows the outer layer of the aorta, the outermost layer of the aorta, to also get nutrient supply. So that's kind of protective for the thoracic area. Right? So the thoracic area, which is that thoracic aortic aneurysm you're seeing over here, right in front of the heart, right? So oftentimes patient might present with thoracic aneurysms and they might call it chest pain, right? Or they might say that they feel a heaviness in their chest. This vasa vasorum kind of protects the aortic aneurysm from happening in the thoracic area simply because of this essentially a dual blood supply kind of thing happening, right? You do not have a vasa vasorum down here though. There's no vasa vasorum here because the vasa vasorum is actually something that kind of links into the kidneys, so it ends there. There's none of that down here. So your abdominal aortic aneurysms are common because of that aspect of things, right? You don't have that protection down there in a sense. So that's what they're talking about here. That's why 90% originate below the renal arteries, because you can get an aneurysm easily there since there isn't that quote-unquote double blood supply. It's not really a double blood supply, but it allows for nutrient exchange and a little more perfusion for the outer layer of the aorta. So below the renal arteries, you're going to get a patient who presents with some kind of bruit. This is often actually discovered incidentally. So they mentioned that here, right? So you see history presenting of the patient. You see usually asymptomatic, which always sucks, right? Any condition that's asymptomatic is the worst because then the patient doesn't know they have it. They take too long to finally come in to show you anything, and you never really realize that the patient has this problem until it becomes symptomatic, at which point it's actually the end of the game, right? So usually asymptomatic and discovered incidentally on exam or radiologic study. So we as physicians now don't really want to discover these things incidentally, so we routinely check patients for that. And that's the routine screening that you have to be very good at for the CK exam. You're going to get questions about patients coming in for their first presentation, maybe someone who's never been to a doctor or hasn't seen a doctor in over 30, 40 years, right? And it's usually going to be a patient who's 65 or above, has some smoking history, although they might not mention it. And since the patient hasn't been to a hospital in more than 30 years, there's a lot of things to order, right? You get a patient who just came in and hasn't had any checkups, so you need to order their CBCs, lipid panels, everything, right? You need to do possibly many, well, not many, but probably an ultrasound, chest x-rays, stuff like that, depending on what other issues they might talk about. But when people present with this kind of stuff, instead of discovering it incidentally, it'd be better if we just routinely screen everyone to see if they have it. It may cause mild abdominal or back pain, but again, like these symptoms are very non-specific. Exam would demonstrate a pulsatile abdominal mass, or what they usually tell you in the question, an abdominal bruit. Now this is very non-specific as well, because it's really only specific for two things. So you could either have the abdominal bruit right in the center of the patient, because that's where the aorta kind of sort of is, or you could have an abdominal bruit that's on either one of the two sides, which would then be related to the renal arteries, right? Because if we come back to our step 1 picture over here, right, if with the same patient, you could have an abdominal bruit anywhere like in this area because of an abdominal aortic aneurysm, or you could have a left side or right sided bruit because you have renal artery stenosis, right? So those cause unilateral bruits. But in a patient, in the real life setting, in the physical setting, it's often difficult to tell if what you're hearing is actually a renal thing or is it an abdominal thing. And if it is a renal artery stenosis question, then that's a whole different set of orders of exams and a whole different set of management, right? Most times when a patient has unilateral renal artery stenosis, they're probably also going to have hypertension. But if your question is about aortic aneurysm, they're going to take out the hypertension. Right, they're going to take out the hypertension. Most likely the patient is going to present with a mildly normal, maybe between the 120 to 130 level of hypertension, which wouldn't really be the biggest problem, right? Because that's like pre-hypertension in a sense. So watch out for that, right? If they give you the hypertension in a patient, then it's more likely a question about probably the renal artery stenosis or something that's supposed to lead to aortic dissection, which really causes a really nice pain to the back, which is a giveaway for the question. And we'll get to that. So here they tell you risk factors include hypertension, high cholesterol, which is going to be related to the atherosclerosis, probably the number one thing. Other vascular diseases, if they have any other vascular disease, especially Marfan or something, then it's a very big risk factor for developing an aneurysm. A positive family history, because Marfan and some of these other things that could cause vascular diseases are actually pretty inheritable. Smoking, which is the strongest predictor of rupture. Right? So again, if you this one parenthesized statement right there makes up a whole new question now, right? Because you could get a question about a patient with an aortic aneurysm. You're reading the question, you start feeling very comfortable, you know what's happening, you're gaining confidence, and then you get to the last sentence and they ask you, what's the strongest predictor of rupture? And then you're like, come on, you couldn't just ask me something more realistic or logical. So you have to remember that the strongest predictor of rupture in these patients, at that point, you wouldn't pick atherosclerosis, you would pick smoking. So this would be a question that would become very hard simply because they would have both answer choices. They would have the atherosclerosis answer choice as well as the smoking answer choice. But it's almost always very easy to pick smoking as an answer choice. The only time you don't pick smoking as an answer choice is with the dissection. Dissection has only to do with hypertension. Step 1 U world, and maybe even step 2 CKU world, but step 1 U world for sure, they made sure they asked questions about aortic dissection where they asked you what was the number 1 risk factor, and they had both answer choices, smoking and atherosclerosis, as well as hypertension. And you had to pick hypertension if you knew it's a dissection problem. Ruptured aneurysms lead to hypertension because now you basically want to imagine a person whose aneurysm popped, so now their aorta is leaking and they're losing blood, right? Tearing abdominal pain that radiates to the back. Now putting this here is kind of unreal because if they had the rupture, then yeah, sure, it's going to have a tearing abdominal pain that radiates to the back, but aortic dissection theoretically also presents with the same abdominal pain that radiates to the back. So you have to use your best clinical judgment and whatever else is given in the question to figure out, if they put this sentence in your question to figure out if it's an aneurysm that ruptured or is it the dissection. And that shouldn't be too hard to figure out simply based off of what else they told you in the question, right? If your patient has very bad, unmanaged hypertension, and they have not been coming in for treatment, don't adhere to the medications, haven't seen a doctor in a long time, then yeah, it's probably the dissection that's happening at that point. So diagnosis, again, screening all men, right? All men 65 to 75 years of age with a history of smoking. That's when you have to screen them for a AAA, right? And one-time screening by ultrasound for AAA is mandatory. Now, of course, if they've had their one-time screening already, then you don't need to keep doing the screening, right? Especially if they maybe don't smoke anymore, right? Stuff like that. Abdominal ultrasound is used for diagnosis or to follow the course of an aneurysm over time. So sometimes you could actually discover an aneurysm and it's not that bad, and then you start treatment, maybe try to get rid of their any of these risk factors, right? Get rid of their hypertension, manage their cholesterol better, tell them to quit smoking, stuff like that. Then maybe their aneurysm won't get worse and they won't need surgical intervention. Abdominal ultrasound is used for diagnosis or to follow the course. CT with contrast or MRA may be useful to determine the precise anatomy. Now you see how both of these things are here. Abdominal ultrasound as well as CT with contrast as well as doing an MRA. Now if you get a question and they ask you what's the next best step, determining which thing to order is really based off of what are you trying to figure out, right? Are you trying to figure out, do they have an aneurysm? Because then you need to do the ultrasound to figure out if they have an aneurysm. But if you're trying to figure out how bad is the aneurysm or where is it, where exactly is the aneurysm located, right? The precise anatomy of the aneurysm would only be seen with CT with contrast or doing an MRA. So that's when you figure out one lab to order over the other. In the real world, we would just order both things. But for exam purposes, next best step is in terms of order of ordering things. So you don't just go ahead and order both things as far as the exam is concerned. Treatment, well, if you have an asymptomatic patient where you discovered it by incident and the lesion is less than 5 centimeters, you just monitor. See, so this would be a case scenario where you would continuously keep doing ultrasound to see the progression of the aortic aneurysm and see if it got better. So less than 5 centimeters. Surgical correction is indicated if the lesion is approaching 6 centimeters. And so more than 5.5 centimeters in the abdominal version or more than 6 in the thoracic. So I just remember the 6 part. That's good enough. So the difference is just between being 5 centimeters to 6 centimeters. That one additional centimeter is a lot for an aorta that's not really supposed to be that thick to begin with. Emergent surgery for symptomatic or ruptured aneurysms, of course, right? If you have a rupture anywhere, that usually requires emergent surgery. You have to go in and check. So this stuff gets really weird because you see this question right here. So let's take a look at it. It says a 72-year-old woman comes to a physician for follow-up care. 1 year ago, she was diagnosed with a 3.8 centimeter infrarenal aortic aneurysm. So that would be an abdominal aortic aneurysm, found incidentally on abdominal ultrasound. She has hypertension, diabetes, and COPD. Current medications include hydrochlorothiazide, lisinopril, glyburide, and albuterol inhaler. So she's taking things for her hypertension. She's taking the glyburide for the diabetes. She has her albuterol inhaler for the COPD exacerbations. She has smoked a pack of cigarettes daily for 45 years. So that's a 45-pack year smoking history, which is very intense. Chances are her aneurysm is only going to get worse. Even if she starts managing her food intake and medication usage better, it's very unlikely that her aneurysm is going to improve and recover. It's very unlikely. Temperature's fine, pulse is fine, respiratory rate, blood pressure is a little elevated, which shows you that chances are she needs another hypertension medication. The hydrochlorothiazide and lisinopril are not doing it for her. Examination shows a faint abdominal bruit. Ultrasonography of the abdomen shows a 4.9 centimeter saccular dilation of the infrarenal aorta. So right there you can already see it's really not at the point where you would have to worry too much, right? It's at 5 centimeters. And we just read that, right? We just read that right here, that if the patient is asymptomatic and the lesion is less than 5 centimeters, you just monitor. Surgical correction is for more than 5.5 centimeters or more than 6 centimeters. But turns out there's actually one more technical thing you need to look out for that isn't mentioned in the book, but this question teaches it. So for this patient, there were 2 answer choices that were very commonly picked. The correct answer was to actually do an elective endovascular aneurysm repair, which is basically surgery, which doesn't really follow with what we've been looking at so far. 30% of people picked the other answer choice, which was to just adjust her CVS risk factors, which is to maintain her hypertension, and do a follow-up ultrasound in 6 months. So this wrong answer choice was what we would all pick if all we read was first aid. And that's kind of unfair, right? First aid should have been able to tell you what this question is about to teach you next. So elective surgical repair is indicated in asymptomatic AAAs that are more than 5.5 centimeters, or in a symptomatic AAA of any size, because they may rupture. So that we knew, and both of those case scenarios don't fit her. Turns out there's a third one, which is this one. Any saccular aneurysm of any size, as in this patient. So they don't mention that here, but if the aneurysm is saccular, if it's a saccular aneurysm, you have to go ahead and do surgery. The rate of growth is key too, and her aneurysm was 3.8 centimeters, but now it's become 4.9 centimeters, so it grew more than a centimeter in 1 year, which also indicates that it's going to need repair. And before even reading any of that, just because we know it's a 72-year-old patient with a 45-pack year smoking history, we already understood that her aneurysm is only going to get worse. So it's better to just do the surgery and help her before it ruptures, at which point she'd be at a much more critical condition. Another answer choice was open repair, but endovascular repair is preferred because it's minimally invasive, right? You never want to do open surgery if you can do a minimally invasive surgery. Conservative management of AAA is indicated when the criteria does not meet for intervention. But this patient's aneurysm is rapidly expanding. So the rapid expansion of an aneurysm is not mentioned in first aid, which is very unfair, right? Because there are students out there that literally just depend on first aid for most of their studying. But we all know that first aid CK is very incomplete, which is why my version with the incorporated questions and key notes really help complete everything, right? Because this one question and explanation here was everything you needed to know to now have full understanding of how to manage a patient that presents with an abdominal aneurysm. Okay, this question is also showing, so if you look at these ultrasound images, right, as well as the CT they're showing you here, these are giving away things that you have to now kind of sort of start getting better at, because CK and STEP in general, even STEP 1, both of them are starting to show more questions with ultrasounds and CTs, things that we have absolutely no experience with in the actual clinical setting, right? Unless you work as an ultrasound tech or you're constantly in the hospital working with any kind of physician, you wouldn't really see these things. So it's nice that these pictures are here, and you should definitely look up more images on Google to have a better training of your eye to be able to catch these things. So here you're seeing, if the question is about an abdominal aortic thing, you're going to know that the question is talking about doing certain things that are falling into this category, and then they'll give you this ultrasound. And if it's such a big opening, it's most likely safe to think that it's an aortic aneurysm. Over here, what I like to use for this is that if I use my circle tool, you can see right here, you see how big the aorta is? The size of the aorta, right? If I move the circle now, the size of the aorta actually mimics the size of the kidney. And that makes no sense, right? Your aorta should not be as big as your kidneys are, right? So that's the giveaway, that this person's aorta is way too expanded. Okay, both of these guys would be case scenarios where you would have to go ahead and start intervention before it ruptures, and then the patient could die, etc., etc. So very good question here to wrap up that topic of an aortic aneurysm. Next thing is an aortic dissection. So on the side they have a little note. Aortic aneurysm is most often associated with atherosclerosis, whereas aortic dissection is commonly linked to hypertension. Very important note to remember, and I've repeated this almost 4 to 5 times already in this one video, because they love trying to trick you into picking this atherosclerosis or smoking answer choice, even though the question is about aortic dissection. So the dissection is a tear, it's a rip. And that's the next topic right here, right? So you can see how this tear is on the top left over here, right? It's literally a rip into the aorta, right? And it only rips from the inside, so outside nothing is wrong. The outer layer of the aorta is perfectly fine. It's a rip from the inside, but what you can imagine in this picture, make it bigger, that once this rip occurs, it's only going to progressively rip, right? It's like peeling a tiny cut in your skin. If you start peeling it, or oftentimes people get little cuts or little skin ruptures right on top of their nail beds. Oftentimes when you start peeling it, it just keeps going, right? And you just rip everything else up. So that's what you would notice here, right? This rupture is going to continuously keep rupturing, and again, this use of this word is something that's going to be confusing too, because this is in a sense a rupture from the inside, but it's a dissection. So keep that in mind. So this dissection will keep going on until either one of these two case scenarios, A or B, occurs, right? And most patients will often actually end up presenting either right when this happened, or they didn't come and then they come later on because of symptoms of one of these two case scenarios. So now, very important to understand how these two case scenarios look different from each other. So if we look at the first one right here, this is the type A, which is an ascending one. Okay, so it goes from the ascending aorta. You see the dissection must have occurred somewhere right here. And of course, inside this dissection, you see the red inside the yellow. So of course, inside the dissection, a lot of blood starts pooling up. This can then continue to the descending aorta, which then becomes really bad, right? So now you have this almost like a tamponade kind of thing around the aorta, right? So you have this pool of blood around the aorta that is going to be very inflammatory for that outer area, and it can just break at any point. It's also going to be compressing on things, and it's just not normal. It's not the normal physiological build. So that's one case scenario. And you see how we just said that it can continue on to the back and go to the descending aorta? It can also continue on to the front. So right here you would have your heart, right? This dissection can also grow towards the front, okay? And then you would have tamponade after that, because it would just go encircling the entire heart, giving you a lot of blood compiling around the heart, which we've already discussed, right? We talked about cardiac tamponade and how this bag of blood around the heart makes it difficult for the heart to beat correctly. And this is most noticeable with the symptoms of pulsus paradoxus and the drop in blood pressure during inspiration. Some of the things we talked about in the last video, simply because during inspiration, more blood comes into the right atrium and right ventricle. And as your right ventricle starts filling up, since it cannot expand outwards, it's just going to push the ventricle into the left ventricle, the interventricular septum. Right? And since you lower the amount of space in the left ventricle, blood pressure falls down during inspiration. This interventricular dependence was the terminology we looked at last time, is something that's going to be very critical in catching the fact that this person must have had a type A ascending aortic dissection, which led to cardiac tamponade. Right? And this is a really nice, simple picture of how a tamponade looks like. So you see how there must have been a rupture over here, and then it continued on to the sac around the heart. And all this blood around the heart is just going to cause this heart to have this fluid little balloon around it, in which the heart can just juggle and shake rather than being firmly where it's supposed to be. That's not good. None of that is good, especially if this patient tries some kind of athletic activity. The next type is the type B, which is some kind of dissection that occurred later on, past the ascending part, past where you would have this isthmus area. And that dissection can just continue downwards also, right? It would ultimately at some point reach where the renal bifurcation is, and again, that can lead to a whole nother set of symptoms as well. So treatment for both of them is very different too. Step 1 summarizes this in a very simplistic manner. If you have the type A, which can cause a cardiac tamponade, you have to do surgery. There's no other solution. It could result in acute aortic regurgitation, because again, you would have a little dilation of the aortic root. So the aortic root that's going into the heart would dilate a little bit, causing the valves to be pulled apart, and then they can open backwards into the left atrium, left ventricle again, right? Back into the left ventricle. So that regurgitation could lead to heart failure and so on and so on, so it needs to be dealt with. Type B is the more preferred form. If you're going to have a dissection, if you can't avoid it, then you would pick to have a type B dissection, which is the distal one right here. Because at least here you're not going to get cardiac tamponade, and you can actually just treat that with just beta blockers. So just think of B for beta blockers, and then vasodilators. So don't forget that. Right? So you have to give them some beta blocker first to maintain their blood pressure, slow down the beating of the heart, because if the heart beats with too much pressure, that pressure is going to get transmitted throughout the aorta, further worsening the dissection. And always remember that the treatment obviously has to do with hypertension, right? So beta blockers are a treatment of hypertension, and the vasodilators, like your calcium channel blockers and stuff, are also a treatment for hypertension. Treat the hypertension. That's what you're doing here. But B for beta, very important to remember that. These are just technical things you get questions on. So if we come back to here, transverse tear in the intima of the vessel that results in blood entering the media, creating a false lumen, because it's not the whole thing. Remember I said the outside of the aorta, the outer part of the pipe, is perfectly fine. This will lead to a hematoma that can then propagate longitudinally, either the ascending type, which can then come down onto the heart and cause tamponade, or the descending type, type B, which you need the beta blockers for. most often occurs at younger ages than compared to the aortic aneurysm, 40 to 60, with a greater frequency in males than in females. The key thing being hypertension being the problem. Now, of course, Montfron, mitral valve prolapse, and trauma are also things that are here, and this could often be a question of trauma, because just like hypertension has high pressures that could cause an aortic dissection, trauma also has high pressures, right? If someone has a really bad car accident, that's usually the classic scenario they'll pick, then they could have trauma to the aorta leading to a dissection. Presentation is going to be a sudden tearing or ripping pain in the anterior chest. So this is not something that's diagnosed incidentally. Very key thing to remember. It's a very little thing, but it helps you figure out the difference between one question over the other, right? Because we just said that the aortic aneurysm guy, that patient is going to present with no symptoms, right? And you incidentally or by screening discover the fact that they had an aortic aneurysm. This patient, though, doesn't come in for anything. They actually came for a very specific issue that's happening, which is their tearing pain that's going to the anterior chest with or without radiation to the back. Right? So if it's on the type A, the type A would just have a lot of pain to the sudden anterior chest, so they're just going to come saying they have chest pain that just started and it's really bad. If there's no radiation to the back, that's actually often going to be indicative of the fact that it's just a descending one, the better one, type B. And that one is not, you just give them beta blockers and they should be okay. Exam patients are typically hypertensive. If hypotensive, consider pericardial tamponade, hypovolemia for blood loss, especially in a trauma incident, or other cardiopulmonary etiologies. Asymmetric pulses and blood pressure measurements or acute limb ischemia are also things you want to look for. The asymmetric pulses are going to occur from this picture. You could tell that, if you look at type B over here, so if it's happening on this side, or if it's happening in between these three great vessels that come out of the aorta, remember that one goes to the right hand and supplies everything to the right side. So maybe the right side stuff isn't affected and your right hand blood pressure is going to be pretty normal. But if the left side is messed up, then that's where the blood pressure is not going to be the same as it was on the right side. Okay. A murmur of aortic regurgitation may be heard because, as we said, the aorta can get expanded and the aortic root is going to pull the valve apart. Neurologic deficits such as paraplegia may be seen if the aortic arch or spinal arteries are involved. Right? Anuria may be seen if the renal artery is involved in the type B, and signs of pericarditis or pericardial tamponade could also show up on ECG. So how do you, initially test for how do you initially diagnose these things on these patients? So they have the same pictures here again, right? Type A and type B, and you can see the differences. Now, there's a difference in what test to order simply based off of how stable the patient is. If the patient is hemodynamically stable, which means they're not losing blood and their blood pressure is pretty normal-ish or pretty standard. Now remember, normal blood pressure, of course, we define it as 120 over 80, but if a certain patient has had normal blood pressure of 130 or 140 their whole, last 10 years or whatever, then that's their normal blood pressure. Always remember that. So if they are hemodynamically stable, you just do a CT angiography, you check, and then you can do an MRA. But remember, the only thing is that MRA can be used if contrast CT is contraindicated. So you can have both answer choices. You can have CT angiography or MRA with contrast CT. Now comes the question of when is MRA with contrast CT contraindicated? Because most students wouldn't really know that unless you've been practicing medicine or you saw that in the question. So it's usually going to be patients with renal insufficiency. If they can't really get rid of the contrast through renal excretion, then you don't do it, right? So that's when you just go ahead and do the CT angiography. If the patient is hemodynamically unstable, then you do a TEE. This is a tracheoesophageal endoscopy, right? It may also be used to visualize details of the proximal aorta and coronary vessels, and can also evaluate for pericardial effusion. Right? So this TEE order as well as CT angiography are the two different answer choices that are going to be very critical. And you'll see when you do your practice questions that many students would pick one or the other, and it's never that it's very nicely weighted towards the correct answer. It's more so going to be like 50% chose the correct answer, but a good 40% chose the other wrong answer. And you can see why they messed up. Right? So very important to make sure you catch that difference between the two scenarios. And then I have this question here that's related to an issue related to cardiac catheterization. Right, so you want to make sure you can check this image out, do the question. We'll look at it together right now, but spend some more time going through this image, because on the bottom they list out simple differences between the three case scenarios here, so you can actually differentiate, because you're going to get a question. It could be one of these three scenarios. You're going to have to perfectly differentiate between A, B, or C, and then order the correct thing accordingly, right? So let's look at how this question goes. This one says a 62-year-old man comes to the office for a follow-up visit a week after after undergoing PCI. In the past 2 months, he has had several episodes of retrosternal chest pain, and a myocardial perfusion scan revealed an area of reversible ischemia on the lateral wall. Coronary angiography was performed through a right femoral access, and a drug-eluting stent was placed in the left circumflex. So now this doesn't really happen that much lately. We don't really use the femoral access that much now. It's not a thing. More so, we're usually just going to use the right hand, put something in through the right hand right here, and then just use access in that manner. He has had no further episodes of chest pain or dyspnea, so that's success with the stenting. Other medical issues include hypertension and hyperlipidemia. He smoked a pack for 35 years and stopped smoking after he was diagnosed with heart disease. Temperature, blood pressure, pulse, pretty standard. Heart sounds and lung auscultation are also normal. Mild swelling in the right inguinal area. So this swelling in the right inguinal area is a giveaway that there's something wrong where blood is pooling up. And when they check, there's a palpable thrill and a continuous murmur on auscultation. Now, for me, when I see continuous murmur, I think of continuous murmurs as something that's happening during systole and diastole, so it's related to left heart and right heart, which then comes back to being related to your arteries and your veins. Right? So if you have a continuous murmur in most questions, if it's not about the heart and it's somewhere else in the body, that's usually because of an AV fistula. And that was what the actual correct answer here was. They asked you what is the most likely cause of his current findings, which is the continuous murmur and the palpable thrill in the inguinal swelling. Then it was just an abnormal AV communication. 56% people picked it, but then 30% of the people picked the other one of these three case scenarios, an arterial pseudoaneurysm. But remember, pseudoaneurysm was this thing right here, which is literally just due to the atherosclerosis topic we were just looking at. Right, so that this patient doesn't have atherosclerosis problems. This patient doesn't have just an aneurysm. This patient has hypertension that can cause a dissection, and a dissection won't exactly do this yet. It could eventually, but not in the way he's presenting. He's already being treated, right? For dissection cases, you have to have the dissection, then you present and get treated. It's never the other way around. So here it was an AV fistula, and they talk about an acute aortic dissection. And this table was given as well, so you could better understand how an aortic dissection would show up. Same summary of the topics we've been talking about. For this patient, though, the explanation is over here for the rest of the topic. Just make sure you know how to differentiate between a hematoma, where you would have a mass but no bruit because there's no blood flow. It's just a hematoma, if anything. The middle case scenario, where you have a bulging pulsatile mass, is pulsatile because it's going with the pulse. Every time blood is passing by, this is going to radiate waves out of it. You're going to feel the pulse. And it's only going to be a systolic bruit because it's only related to your left heart and systole and your ventricle contracting and blood going into the aorta. Then you have the case scenario of our patient where somehow you must have punctured the aorta and connected it to the vena cava or some other vein. And then, of course, naturally they developed endothelial recovery, which then ended up causing a connection. And that's terrible. Having an AV fistula is really bad for your body because essentially you think of that as doubling the number of arteries and doubling the number of veins, because all your arteries are not connected to veins. So those two are supposed to be separate systems, only linked by the heart and lungs. The heart and lungs, and that's it. If you have a connection anywhere else, then you have this issue where you're going to not have a mass because there's no pooling of blood really, but you're going to have a continuous bruit and a palpable thrill because you're going to feel blood both ways. You're going to feel blood when the aorta is getting blood from the left ventricle. You're also going to feel blood when the inferior vena cava and superior vena cava, whatever vein it is returning blood to the right ventricle, and it's terrible. Really bad for them. This case scenario can also occur after stab injuries in patients who might have been in some kind of altercation. So that's another question you get. Treatment, as we talked about, blood pressure control is the main thing for aortic dissection. Got to get the blood pressure under control. Important to monitor and medically manage blood pressure and heart rate as necessary. Avoid thrombolytics. So again, very critical thing, this part right here, because this is going to be an answer choice. Your question could be written in a way where they're kind of making you lean towards picking a thrombolytic and as an answer choice. But you don't want that. You don't want to stop thrombolysis in them, right? You don't want to cause thrombolysis in them, right? Because thrombolytics would break any thrombus that would try to fix this, right? You need a thrombus to try to kind of fix this stuff and not make this worse. So if you give them a thrombolytic, you make it worse. Begin IV beta blockers like IV labetalol before starting vasodilators like nitroprusside to prevent reflex tachycardia. So they spelled it out for you here. But when I said it earlier on step 1, right, where they just said give beta blockers, then give a vasodilator, this topic is actually a very high-yield topic taught within pharmacology, within cardiovascular, within all the cardiovascular questions you see, the topic of reflex tachycardia, right? Every time you change blood pressure, since blood pressure and heart rate are all related to cardiac output through that one equation, if you change one thing in an equation, another number has to change to keep the equation equal, right? Keep it similar to how it originally was. So you give the beta blocker to prevent that reflex tachycardia issue from occurring. Right? You don't want their heart rate to go up simply because you started doing something to their blood pressure. All patients with type A, thoracic ascending dissections that can lead to cardiac tamponade need surgery. And all patients with type B, descending dissections that can go down to their renal arteries need to be managed with blood pressure management. Surgery is only reserved if there is some kind of leakage in a type B patient or a rupture or some organ isn't working correctly, mainly the kidney stuff. So you look for their creatinine levels. And that's it for the aortic dissection topic. Last thing here is a DVT, deep vein thrombosis. Usually going to be a patient who is in some kind of immobility, right? Took a long 14, 15-hour flight, has been hospitalized for a very long period, and maybe they weren't really moving around much, was in a coma, right? Any of these things are all case scenarios where you have patients that are very immobile. Also truck drivers, right? Patients that work as a truck driver, those patients also don't have much mobility. They just sit and drive all day, all night, whatever their shift is. So clot formation in the large veins of the extremities or pelvis, that's your DVT. The classic virtual triad, this is what you're going to look for, of risk factors includes venous stasis from long haul flights, prolonged bed rest, obesity, immobility, or incompetent venous valves in the lower extremities. Endothelial trauma, such as surgery, injury to the lower extremities, or some kind of accident, and a hypercoagulable state, which is many things. This is a good list of them, but there are many others. So thrombophilia, malignancy causes you to be more hypercoagulable. Pregnancy has physiological hypercoagulability, and an oral contraceptive use also makes the patient more hypercoagulable. Right? So they all have this virtual triad of things, or things that will lead to a patient having increased risk. So it's listed out nicely right here. Increased risk of having a DVT. They'll present with actual pain, which is nice because then you can actually see that in the patient and do something about it. Presents with unilateral lower extremity pain and swelling. Calf warmth, tenderness, and erythema may be present. You look for this thing called a Homan Sign. Homan Sign is calf tenderness with passive foot dorsiflexion. So this is actually shown up in ANBOS and New World Questions, and I wrote more about it over here. There's a YouTube video to see this as well. You can check that out because it's a good experience to have. Since you're not getting much clinical experience right now, you want to have this clinical experience through YouTube and other forms of media before you actually go in for your first year of residency, where you risk the chance of having some attending physician embarrass you by asking you, oh, what's wrong with this patient, right? Because they'll show you the Homan Sign in the patient, and then they'll just look at you and be like, okay, what's wrong with this patient, Amir? And then if you don't know, it just makes you look really bad. So you definitely want to check out this video, see what happens with them, but this can be given in a question to you too. So you don't want to lose that, right? They're going to give a patient who's trying to do passive foot dorsiflexion, right? And it hurts their calf. And that's a very good indicator that there might be a chance of DVT. However, this has very poor sensitivity and specificity for DVT, because this can of course occur for many other reasons. I mean, a person could just have passive foot dorsiflexion pain if they just had a really bad accident and they can't flex their foot. Use pretest clinical probability scoring for DVT, which is the Wells score. So the Wells score combined with the Homan Sign will be much more specific. And now you start seeing this diagram, and this is where they get step students, right? So you get a patient, you have this clinical suspicion that they might have a DVT, but the other thing that can happen is a pulmonary embolism. So you have to figure out between the two. So you assess clinical likelihood. If you think it's a DVT, you go to this top half. DVT. Is the Wells score less than 2 or the Wells score is more than 2? Right? That's what they're defining as low and not low. Okay? Okay, I don't like the fact that they use the word low because low doesn't quantify it. I don't know why they just call it a low well score. You should know the number it quantifies by, and this is the table to show you how you give points. Are you seeing the points you can give to a patient based off of whatever scenarios are that are there? So these points, as we've seen from the other things that occurred in cardiovascular, are not things you memorize. Okay, you don't need to memorize this per se. It should be pretty logical and reasonable. If you have a patient with clinical signs and symptoms of DVT, you immediately give them 3 points. Pulmonary embolism is the #1 diagnosis or equally likely, then you add another 3 points. If it's not, if you don't think it's pulmonary embolism, you don't add those 3 points. Then come the rest of the things that you're going to have to use your logic for. Is their heart rate very high? Yes, add 1.5 points. Have they had any reason to be immobile for a long period in their history recently? Yes, add another 1.5 points. Have they had a DVT or pulmonary embolism pretty recently? Maybe earlier the same year? Add another 1.5 points. And then hemoptysis and malignancy with treatment within 6 months, right? If they've had, now hemoptysis and malignancy kind of go hand in hand. Usually if the question is about someone who might have had lung cancer recently, right? So oftentimes questions try to give you stories that are very prolonged and annoying. And you start thinking, how is the first part of this question related to the second half? And it is. It's usually going to be a question about a patient who had lung cancer. They'll tell you all the things they did for that patient's lung cancer. They'll then tell you they treated it and no more lung cancer is there. And then maybe 2 to 3 months later, the patient is now presenting today with something that looks like a DVT. So what you have to realize is that they're still hypercoagulable, right? None of the treatment for cancer is anticoagulants, really. You don't really, per se, put patients on warfarin or heparin that quickly because it's not a good idea to take warfarin or any anticoagulant along with chemotherapeutic drugs or even chemotherapy, radiation, and stuff like that. So hemoptysis is more so a sign of you thinking something's wrong with this patient in terms of maybe possibly lung cancer. That's the only thing we first think of when someone presents with hemoptysis. Either that or pneumonia, right? So pneumonia is going to be fever and stuff, and that's a whole different scenario. You won't think of that here. So you add all those points up, and then this table here helps you figure out the probability. So what's considered a lower probability is a score less than 2. Because at that point, you would really not be adding any of these points. Maybe they'll get 1.5 for one of these things, and then that's it. Right? So then that's not someone who's probably got a DVT. It's most likely something else. And if their score is more than 6, you added enough of these things with one of the 3s from up here to give them a high score. So what low score basically means is you never added a 3. You never added a 3. You added one of these 1.5s, and then that's it. So it's a pretty good table. Not much overlap. So if we come back to this now, so low score less than 2, you then order a D-dimer test. Right? So D-dimers are your breakdown products, right? D-dimer is a sensitive test for DVTs. It can rule out a DVT, so it's best used to screen patients with a low chance of a DVT. If you know a patient doesn't have DVT, you should officially rule out the diagnosis with something very sensitive. It comes from the snout mnemonic. And you use the D-dimer. Now, if you look at a D-dimer, it's normal, then you're good to go. You're fine, no DVT. However, if the D-dimer turns out to be high, then maybe your well score didn't really identify what's actually happening, and you now have to do imaging. So now, why not just go ahead from DVT to here, right? Why not just go ahead and immediately order imaging? Well, maybe in the real world we'll do this, sure. But as far as exams are concerned, it's technical, right? Tests are always very technical. So you have to do the well score, then D-dimer, then imaging. Because, of course, insurances charge a lot of money for these imagings. I mean, even doing one chest x-ray in America could range from anywhere from $300 to $1,000 depending on where you got the x-ray done, like what company did it. So, of course, that money doesn't come from the patient, but sometimes it does. In fact, more than common, it will, because not everyone is insured that well. And if they are, it's still likely that their insurance is not going to pay for it. And of course, if the well score is high, then you just jump to imaging. You don't need to do the D-dimer. So a D-dimer is a sensitive test just to officially rule something out that you already think is very unlikely. Okay. Now, same Wells criteria and everything is also used for the management of pulmonary embolism, which is a respiratory topic, right? So that's why I've been telling you guys, study the respiratory stuff from step 1 and CK simultaneously while doing cardiovascular. For pulmonary embolism, you do the same thing. You do the Wells score. You see if it's high or not high. So you see here how they change the terminology between low and high. Right? Terminology has changed. Either way, if you do evaluation of a well-scored criteria for a pulmonary embolism patient and it is high, then again you just jump to imaging. Right? That's it. You just do the imaging and you'll confirm it. But if their pulmonary embolism well score is not high, which means that it falls in the moderate probability area, less than 6, then you go ahead and do the D-dimer, and once again, it'll help you figure out if you do imaging. Right? So this flow chart over here is not that ridiculous. It does take some application though. Once you do a question or two where you successfully were able to identify the key things that you would add points for, you're going to be fine. You don't need to worry about remembering this as 1.5 though. Okay, so I'll tell you right now, honestly, when I do these questions, I always just add 1 point. Everything is 1 point. Just do 1 point. You'll see that you'll start seeing more than 2 points very quickly in most patients. So don't worry about what's 1.5 or what's 3. The 3 is obvious actually. The 3 is pretty critical. If you know a patient has DVT or if you know a patient has PE, you immediately add 3 points and you're no longer considered a low score. Right? So you go ahead and do the imaging. So imaging for DVT is actually more commonly ordered. You see how easy it is to order imaging for DVT? The score just has to be not low, right? That's why the significance of these terms is key, right? You see how they call this not low, whereas here they say it's not high. Okay, being a high score or a low score is what indicates what test you order. And for a step, that's a critical little bullshit thing that you can't really do anything about, right? So that's just what you have to deal with. So ordering imaging for a DVT is very common because all you need is the well score to be more than 2 points. If you think they have a DVT, you just do imaging, you're done. For pulmonary embolism, you don't always order imaging. So you're going to see that when you get to respiratory questions, that you get a patient, you read the question, you're pretty sure it's a pulmonary embolism, but you don't order the D-dimer thing because as long as you have, you're pretty sure that it's a pulmonary embolism, you do the score adding, right, and you get like 5 points. And now you're thinking, okay, this is definitely pulmonary embolism, let's do the imaging. No, you can't because you need a very high score to order imaging. So you see how for pulmonary embolism, you would not be ordering imaging that much. And that's a very common mistake a lot of students are going to make in those UWorld questions. You'll see that, some people pick D-dimer, but more people actually end up picking imaging is necessary. All right, so don't fall for that when you get to respiratory. Either way, D-dimer tests should be ordered, sensitive but not specific. And if it's elevated, then you know it's a DVT, right? And if it's elevated, you know it's a DVT. You can do imaging to confirm, and you're done with that. Right? So that's the whole topic of DVT. Not the worst case scenario. Just get some annoying questions where they, really talk about the Homan sign, and you have to know what that looks like. At least verbally know how it looks like. If D-dimer is elevated, patient has a high to intermediate clinical probability, Doppler ultrasound is done. Right? You do the ultrasound, which is the imaging of choice. So you see how they wrote just imaging test is needed? That's annoying too, right? Why would they write imaging is needed like we're teaching kindergartners or something? Just put the fact that you order an ultrasound. Right? So know that. And if you wanna erase this and put ultrasound right here for your own purposes, go for it because that's all you would really order. They put imaging there as if there's like 50 different options or something. Hospitalized patients should receive DVT prophylaxis consisting of exercise as tolerated, anti-thromboembolic stockings, and subcutaneous LMWH or unfractionated heparin. Now this leads to another set of questions too. You're going to get patients who are hospitalized for something, so it's important to realize that when a patient gets hospitalized, nurses will come to them and tell them, hey, let's go for a walk. And you help them go take a walk somewhere, come back, you do these compression exercises on their feet. If a patient is in a coma, you have to do compressive exercises on their legs to really squeeze their leg muscles continuously to keep blood flow going because they're just in a coma, they're just laying there, they're not getting enough activity. And then there's this topic. So you see this image I put over here? This is a filter, an IVC filter that you can put in a patient to catch blood clots. Right? So IVC filter, putting an IVC filter will be something you'll see in answer choices. You want to be very careful where you pick that. Right? You don't always go for it. You don't always put that in a patient. But for some people, it might be necessary. And the key person is this one in the middle right here. In patients with contraindications for anticoagulation, maybe they need to be coagulative, an IVC filter should be placed. This is a very rare scenario, but it occurs. So you want to know it. Check this question out too, by the way. Look, only 30% of people got it correct, and 40% chose the wrong answer, which was exercise, which you would really think is the correct answer choice. But always keep in mind with these things, telling a patient to exercise, eat better, etc., etc. These are not things you can control. You can suggest it all you want, and you can really break it down and give them a good regimen. but you don't know if they're going to go do it. So prescribing the clopidogrel here was the better answer choice, because you know clopidogrel will do its thing once they eat it. If they choose not to eat it, that's on them at that point. Last thing in this topic to wrap up cardiovascular was peripheral artery disease. So this is a very insane topic, because peripheral artery disease can be looked at from many different perspectives. You can get different kinds of problems in the foot related to either peripheral artery disease, a diabetic foot ulcer, or incompetent venous valves. All three of these foot ulcerations occur in completely different places. Right? It's very important to see those pictures for these things as you go along. So I've done that. I've put pictures for everything throughout the book. You'll see when you get to failing of the venous capacitance from the legs. Right? So if you have bad valves in the legs, that venous stasis causes a different ulcer. You're going to have another patient with a diabetic foot ulcer, and then there's this one with the ischemia that occurs from peripheral artery disease, defined as a restriction of the blood supply to the extremities because of some kind of atherosclerotic plaque somewhere in the legs, right, with the femoral artery or something like that. The lower extremities are most commonly affected, especially in patients who don't have much mobility. Clinical manifestations depend on the vessels involved, the extent and rate of obstruction, and the presence of collateral blood flow. Presents with intermittent claudication, the biggest giveaway. Patient's going to tell you that they take a little walk and their legs start hurting. Now, this topic, let me see if I can find it really quickly. Where was this discussed? I'm pretty sure we looked at it pretty recently too. There's a very nice image somewhere. I'm going to try to see if I can find it for you guys, which talks about which arteries get involved for different kinds of pains in the leg. Yeah, I don't have it here. So what it was that there was an image of the arterial blood supply of the legs, right? And it broke it down for you. You had your femoral artery, then you had your popliteal artery down here behind the knee, right? And then after that, you had different breakups of the popliteal artery, such as the tibial artery, right? 3 different places. So depending on where the where the plaque is, the claudication is different. So for example, if the plaque is over here in their tibial artery, this is what the image was showing. If their plaque is in the tibial artery, their pain is only going to be below that. Okay, so they're going to feel pain in their lower leg, in their feet, stuff like that. If the plaque is in the popliteal artery, behind the knee somewhere, then they're going to have pain in this entire region. And lastly, if their plaque is somewhere higher up after the aortic bifurcation, so maybe the femoral artery, then they're going to have pain in the entire leg from walking, right? The upper thigh and everything. So these are things that you get weird technical questions on. This was basically all that picture showed. It was a very informative image because you get questions which ask you where would you expect the patient to have pain. So then you have to figure out what artery was involved and pick an answer based off of that. It could also be a question the other way around. They could tell you where the pain is and then ask you which artery would you expect the plaque to be in. So then based off the pain, you pick which artery you want to pick, just like I showed you in that drawing I just made. So that claudication is one thing. And that's what they're kind of breaking down for you here, right? It's the calf, thigh, and buttock. Right? That's the breakdown. I think the picture should be, I don't even know where, did we talk about it here already? Let me just scroll up real quick. No, not that one. Let's see. Yeah, I'm not sure where that picture was being discussed. I'm pretty sure I looked at it with either this or the Step 1 class pretty recently. So when I'll find it again before our next session and I'll show it to you guys. But what that image had actually basically done was break down this separation that we're seeing right here. Right, so the difference between, where are we? Yeah, it's the difference between it being in the calf, thigh, or buttock. And that's what we were looking for. Let me just see if I can find it real quick. Oh, okay, yeah. So this is the picture. Let me put it in the book for you guys, and then you can see it. So this picture, you see how it is right here. So this is what our topic right now is related to. So you can see how location of blockage, iliac artery, femoral artery, popliteal artery, tibial artery, as I was talking about, that determines where you would feel the pain. So if your patient presents with a certain pain, you can pick the artery. And if they tell you which artery has the plaque, you can pick the pain. So this is a very important image to have in this section. Other than that, as the disease progresses, you could have critical limb ischemia. Pain occurs at rest as well. Painful, cold, numb foot is characteristic of limb ischemia because they're not getting blood supply. So you see how his nail beds over here and the toes are becoming very blue because blood is not reaching there. You're also going to have a lot of pallor because basically it's anemia at that point. For more proximal lesions, there will be claudication and weak pulses below the area of occlusion. Right? Aortoiliac disease causes Leriche syndrome, hip, thigh, and buttock claudication, as well as impotence. Okay, so this is another topic you would look out for as an answer choice. They can ask you about that. And symmetric atrophy of bilateral lower extremities. The Berger angle, so remember, most things related to Berger are smoking or atherosclerotic events. So they're talking here about a Berger angle of less than 20 degrees and a capillary filling time of more than 15 seconds are both seen in severe ischemia. So they'll tell you this directly in the question. They'll tell you like the Berger angle is 10. That's ischemic. That's not good. Acute ischemia may be due to thrombosis in situ, emboli from cardiac origin in a patient who might have atrial fibrillation, graft or angioplasty occlusion, or a really bad accident. Acute occlusions commonly occur at bifurcations distal to the last palpable pulse. Right? If you still have a palpable pulse, then up to there things are okay. It's after that point that you must have some kind of blockade that isn't letting the pulse being palpated. Maybe in your tibial arteries you can't feel the pulse. That's when you know there's peripheral artery disease somewhere that's not allowing blood to come to the tibia correctly. And then atheroembolism. So atheroembolism, this thing with the blue toe syndrome, is another really high yield topic. Right? And there are questions about these things throughout the trauma chapter and stuff like that. You're going to see that. This is also often seen in patients who had maybe a fracture of their long bones of the leg. And then, of course, you know that big fractures like that, even though you might repair it and whatever, are often going to lead to fat embolisms. And that fat embolism can go ahead and plug your tibial artery as well, leading to blue toe syndrome like this. Right? Chronic ischemia, which is a lack of blood perfusion, can lead to muscle atrophy, pallor, loss of sweat and sebaceous glands, cyanosis, hair loss. These are little things they'll mention in the question. They'll tell you that the toe doesn't have hairs. No hairs growing on the toes at all. That's bad. That means that there was not enough blood supply to actually grow hair there. Diagnosing is not so bad. You do the ABI, ankle brachial index test, right? You identify any of the risk factors, of course, and that's clinical evaluation. But actual evaluation is through the ankle brachial index test, which can provide an objective evidence of atherosclerosis. The rest pain usually occurs with an ABI of less than 0.4. A very high ABI can indicate calcification of the arteries. So your ABI tells you what's happening. And this key fact table here is basically related to the image we were just looking at. You see how they once again tell you about impotence. So if they give you impotence, that's a buttock claudication. Aortoiliac disease. It would be related to the iliac part of that image we had just posted here. Right? Iliac artery occlusion over here, some kind of plaque in this area, would also lead to your impotence in that patient. So you could do the ABI, you could do a Doppler ultrasound, which identifies the stenosis and occlusion. Normal ankle Doppler readings are more than 90% of the brachial readings. And then most accurate test would be to do an angiography, which literally means going in and looking at it all. Right? So of course it's very, very accurate. Often not necessary unless revascularization is indicated. So even though it is the most accurate test, you don't really do an angiography in most patients unless you're going to revascularize them. This is why when you do cardiac things, you could do an angiography because you go do the angiography of the heart and you revascularize the heart. You don't always revascularize the leg if you don't really need to. Treatment is with acute symptomatic ischemia. You would give them heparin, prompt revascularization, address any of their smoking and hypertension and stuff like that, educate them about foot care, checking and stuff like that. Managing their diabetes is very critical because you don't want peripheral artery disease to be further complicated with diabetic foot ulcers. Cilostazol is effective medication in intermittent claudication. This topic was a big topic in step 1 too. Okay, you had to pick this as an answer choice. If they're going to ask you what's the best treatment for their intermittent claudication, just put them on cilostazol and then start dealing with whatever plaque they might have, if they need surgery, etc., etc. Antiplatelet agents like aspirin or varenicline do not consistently reduce symptoms, but they do decrease the risk for associated cardiovascular mortality. So you still give aspirin, right? Aspirin is one of the most commonly taken medications in the world. Everyone takes aspirin after a certain point in their life every day. Surgery for arterial bypass can be done. Percutaneous transluminal angioplasty can be done, and you could stent. Or you might have to do amputation if there's nothing else that can save them, right? So this is showing you the ankle brachial index. If you've never seen how an ankle brachial index is done, this diagram will help you understand that. And that's basically the rest, the wrap up of peripheral artery disease. These topics I wanted to talk about a little more because they present in more vague ways and more overlapping ways on STEP. Right? You can see how there was a lot of overlap between dissection of the aorta and aortic aneurysm, and then you can see how there's a lot of confusion that can occur with peripheral artery disease versus venous insufficiency of the legs versus diabetic foot ulcers. Right? Very annoying that they have so much overlap. Lymphedema is not that big of a topic. It's a very simple read, and so is syncope. I'm not really sure why they even have a separate thing for syncope. Syncope is more so just related to hypotension or things related to the Beers criteria of list of medications you do not give to elderly people because you don't want someone above 50 or 60 to have syncope and then they fall and they die. Right? Falling can be fatal, so you want to make sure you just go ahead and read some of this. This is stuff you could just read, and more importantly, check out the questions I have here, because this one here, for example, the correct answer was decreased bilateral femoral pulses because of the placement of his pain. Right? He has pain in his buttocks, so that's how you knew that it had to be the femoral pulses that would be decreased, because his block is probably above the femoral, which is the iliac artery. Right? This patient most likely also had erectile dysfunction, as you can see here. So wonderful question related to the image I was trying to find for you guys, right? And that's what this one is. This is another amazing question because only 25% of people pick the correct answer choice of doing an echo. So you see how this question is something you don't want to fall into. So wonderful question to have here. And then this one here, which had this table of their labs and whatnot, and you just had to realize that this is blue toe syndrome in a patient who had cholesterol embolization after some kind of procedure or catheterization. So very good questions of 3 different completely non-overlapping scenarios that are related to the same issues we just talked about. So check them out, and then we're done with cardiovascular. I'm going to email everyone about what's going to happen with adding videos, adding you guys access to dermatology, ethics, and epidemiology, biostats, all of that. And next time we talk, we'll delve into endocrinology. Thanks a lot for joining, guys, and I'll see you guys again later.